I welcome you all in this interactive session. Myself is Professor Ravikant, Head Department of Internal Medicine, AIMS Rishikesh, and Dr. Rifika is Fellow in Diabetes, as well as Dr. Aishwarya on my right. And we shall be talking about the oral anti-diabetic drugs in this session. For this, I invite Dr. Rifika for her presentation, and today's focus of discussion will be conventional oral anti-diabetic drugs. So over to Dr. Rifika for her presentation.
Hello everyone. So in this video we are going to discuss about the conventional oral antidiabetic agents. So currently there are 10 classes of orally available pharmacological agents. We have sulfonylureas, we have meglitinides, we have metformin, thiazolidinediones and alpha glucosidase inhibitors. Apart from these we have some newer agents like DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, bile acid sequestrants and dopamine agonist. So today's objectives we are going to discuss about these 5 classes of drugs: sulfonylureas, meglitinides, metformin, thiazolidinediones and alpha glucosidase inhibitors. So first, coming to the insulin secretagogues. Firstly, they include sulfonylureas and meglitinides. First, we are going to discuss about sulfonylureas. We have 3 generations of sulfonylureas: first, second, and third. First generation include drugs like tolbutamide, tolzamide, chlorpropamide. We hardly use these drugs these days. Second generation and third generation are commonly used. Second generation include glibenclamide, glipizide, gliclazide, and third generation include glimepiride, gliclazide, modified release, and glipizide. So how does they act? Sulfonylureas, they are the insulin secretagogues that lower blood glucose levels by directly stimulating glucose independent insulin secretion by the pancreatic beta cells. Now what happened is, through the concerted efforts of GLUT2 receptor, glucokinase enzyme and glucose metabolism, the pancreatic beta cells sense the blood glucose levels and secrete the appropriate amount of insulin in response. So this glucose metabolism leads to ATP generation and increases the intracellular ratio of ATP to ADP, which results in the closure of ATP sensitive potassium channels on the plasma membrane. So closure of this channel depolarizes the membrane and triggers the opening of voltage sensitive calcium channels, leading to the rapid influx of calcium. Intracellular increase in calcium causes an alteration in the cytoskeleton and stimulates the translocation of insulin containing secretory granules to the plasma membrane and hence increases the insulin secretion. So in this image we can see that the potassium ATPase channel have binding site for sulfonylureas and meglitinides. One thing to note in this that the sulfonylureas and meglitinides have different receptors for binding to ATP sensitive potassium channels. So binding to these channels lead to depolarization of the membrane due to closure of this channel, and which leads to calcium influx, which further enhances the insulin secretion. So the potassium ATP channel is comprised of 2 subunits, both of which are required for the channel to be functional. One subunit contains the cytoplasmic binding sites for both sulfonylureas and ATP and is designated as sulfonylurea receptor type 1. The other subunit is the potassium channel, which acts as a pore-forming subunit. Either an increase in the ATP to ADP ratio or ligand binding by sulfonylureas or meglitinides to sulfonylurea receptor 1 results in the closure of these potassium ATP channel and insulin secretion. In addition to binding to sulfonylurea receptor 1, sulfonylureas also bind to EPAC2, which is a protein activated by CAMP. So in this image, we can see that sulfonylurea like gliclazide, it binds only to sulfonylurea receptor 1, while other sulfonylureas have affinity for EPAC2 receptor also. So in this diagram, we can see that the cardiac membrane has sulfonylurea receptor type 2A. So what are they for? Ischemic preconditioning refers to a phenomena in which a tissue is rendered resistant to the deleterious effects of prolonged ischemia by previous exposure to brief periods of vascular occlusion. So in the heart, it has been suggested that ATP-sensitive potassium channels may represent important effectors of the preconditioning phenomena. Sulfonylureas inhibit the mitochondrial potassium ATP channels in the cardiac myocytes, which contributes to the impairment of this ischemic preconditioning. So the sulfonylurea 2A receptor or KIR 6.2, it is present in the cardiac cell membrane, which closely mimics the SUR1 receptor. First generation sulfonylureas like glibenclamide, they prevent cardioprotection induced by ischemia by interacting with mitochondrial potassium ATP channels, whereas the second generation sulfonylureas are thought not to interfere with this ischemic preconditioning. Gliclazide is more selective, blocking beta cell potassium ATP channels with high affinity but not the cardiac or smooth muscle types. So it does not impair ischemic preconditioning. So these are the various sulfonylureas commonly used are glipizide, gliclazide, extended release gliclazide and glimepiride. The starting dose for these drugs is minimal only. Glipizide is 2.5, gliclazide extended release is 30, gliclazide is 40, glimepiride is 1 mg. But we can increase to a maximum total daily dose. The average duration of action of gliclazide and glimepiride is around 10 to 24 hours, while glipizide is short acting, which has a duration of action of 4 to 6 hours. So gliclazide, besides its role as an anti-diabetic, it has a favorable influence over platelet aggregation and fibrinolysis. Gliclazide has antioxidant properties as well. It reduces markers of endothelial inflammation and prevents glucose-induced apoptosis of endothelial cells. Weight gain is usually not observed in subjects with gliclazide. It also reduces the addition of monocytes to the endothelial cells, and it does not interfere with ischemic preconditioning. This has been discussed previously. Glimepiride, now it has a rapid onset and prolonged duration of action. It is more selectively for beta cells potassium ATP channels. It binds to 65 kilodalton receptor, leading to more rapid onset and longer duration of glucose lowering effects, while the other sulfonylurea, they bind to 140 kilodalton receptors. Glimepiride does not restore first phase insulin secretion, it increases the second phase insulin secretion and has whole body glucose uptake and increases insulin sensitivity. Due to poor binding to cardiac tissue, the interference with ischemic reconditioning is less than other sulfonylureas. So in this image, we can see that there are two type of receptors. One is 140 kilodalton and other is 65 kilodalton. So glimepiride mainly binds with the 65 kilodalton receptor and the other sulfonylureas bind with the 140 kilodalton receptor. What are the other actions of sulfonylureas? They decrease the hepatic insulin clearance, they inhibit glucagon secretion from pancreatic alpha cells, and they enhance insulin sensitivity in the peripheral tissues. The effect of sulfonylureas as monotherapy or when added to the metformin therapy on HbA1c levels varies, but typically results in reductions of HbA1c approximately 0.5 to 1.5%. If the patients initially have high HbA1c levels, their decrease can be in the range of 1.5 to 2%. What are the side effects of sulfonylureas? They can cause hypoglycemia, they can cause weight gain. The rare side effect includes intrahepatic cholestasis, allergic skin reactions, including photosensitivity and erythroderma. So what are the advantages and disadvantages? Advantages include they are inexpensive, rapidly acting, once a day administration is possible, and they have long history of use. But considering the disadvantages like hypoglycemia, weight gain, limited durability, and we have to need to titrate the dose as per the patient requirement. Next, we are going to discuss about meglitinides. They are also insulin secretagogues. So they are non-sulfonylurea insulin secretagogues. The insulinotropic action of meglitinides is mediated via the inhibition of ATP-dependent potassium ion channels, which results in depolarization of the cell membrane and influx of the calcium ions through voltage-gated channels, thus leading to increased degranulation and subsequent insulin release, similarly that we have seen with sulfonylureas. Though the action is similar to sulfonylurea, the receptors are different. Unlike sulfonylureas, the repaglinide and netaglinide stimulation of insulin secretion is dependent on the presence of glucose. As glucose level decreases, insulin secretion decreases, which reduces the risk of hypoglycemia compared with other sulfonylureas. So meglitinides, we have two drugs currently we are using, repaglinide and netaglinide. Starting dose of repaglinide is 0.5 mg per meal and netaglinide is 60 mg per meal. But we can extend to maximum daily requirement for 60 mg per day for repaglinide and 360 mg per day for netaglinide. And we have to give these drugs with meal around 3 to 4 doses per day. So if the post-meal high blood sugar is the main concern, then and fasting blood sugar levels are mostly normal, so medication like netaglenite, which doesn't greatly affect fasting glucose, would be the best. But if we need to lower both fasting and post-meal glucose, a longer acting option like repaglenite is preferable. What are the therapeutic applications for meglitinides? They have low incidence of hypoglycemia. There is flexibility in mealtime dosing. There is no significant increase in the body weight. They can be used in mild to moderate renal failure. They have rapid onset and short duration of action, results in the ability of this class of drugs to predominantly reduce postprandial glucose levels. What are the disadvantages? We need to give frequent dosing. Meglitinides can cause hypoglycemia, but the risk of severe hypoglycemia is less. And mainly they are for mild diabetes mellitus and generally as a first line single agent with minimal adjuvant potential. They can lead to weight gain, which is more with repaglinide as compared to netaglinide. Because meglitinides are metabolized by the liver, these drugs should be used cautiously in patients with impaired liver function. So now we are going to discuss about bigonides. The drug of this class is metformin. So metformin, how does it act? It decreases the hepatic glucose production by decreasing the glycogenolysis and gluconeogenesis, and it improves the hepatic insulin sensitivity. Hyperinsulinemia is reduced and there is decrease in the hepatic glucose production, which results in decrease in the fasting glucose levels. In addition, it also increases intestinal glucose utilization and stimulates the GLP-1 secretion. So in this diagram, we can see that metformin, by acting on the liver cells, it increases the AMPK levels and ultimately decreases the fatty acid synthesis and gluconeogenesis. Hence, it reduces the chances of fatty liver and decreases the insulin resistance. Also, by acting on skeletal muscles, by increasing the AMPK levels, it increases the glucose uptake by skeletal muscles. So metformin inhibits mitochondrial ATP production by inhibition of complex 1 of the respiratory chain. The decrease in the ATP production could decrease the hepatic gluconeogenesis. It also leads to an increase in the AMP levels, which is a potent allosteric inhibitor of fructose 1,6-bisphosphatase, which is a key enzyme in the gluconeogenesis. High AMP levels inhibit the adenylate cyclase, reducing the cyclic AMP formation in response to glucagon, which also decreases the glycogenolysis and gluconeogenesis. So the increase in AMP also activates AMP activated protein kinase, which activates catabolic pathways leading to decreased gluconeogenesis, decreased fatty acid synthesis, and increased fatty acid oxidation. The change in fatty acid metabolism are thought to account for the improvement in hepatic insulin sensitivity and the decrease in serum triglyceride levels. Metformin also inhibits glycerol 3-phosphate dehydrogenase and results in a decreased conversion of glycerol and lactate to glucose. So the typical reduction in HbA1c with metformin therapy is in the range of 1 to 2%. It is weight neutral or can sometimes result in the modest weight loss. It decreases the serum triglyceride levels and LDL-C levels without altering HDL cholesterol. These effects may account for the beneficial effects on cardiovascular disease. In patients with PCOS, metformin lowers the serum androgen levels, increases the ovulations, and improves menstrual frequency. So the usual starting dose of metformin is 500 mg twice a day with meals, and we can titrate and increase the dose every 1 to 2 weeks. The maximum dose is 2550 mg per day, which can be given as 850 mg 3 times per day with meals. The dose of metformin need to be adjusted based on the renal function and liver functions. The common side effects of metformin are diarrhea, nausea, abdominal discomfort, lactic acidosis, and vitamin B12 deficiency. So, how does metformin leads to lactic acidosis? The accumulation of metformin in case of overdose or acute renal failure cases, there is more stronger inhibition of mitochondrial complex 1 activity, which leads to reduction in the ATP production and activation of the AMPK to compensate for decrease in available energy. This results in the stimulation of glycolysis and production of lactate and stimulation of fatty acid beta oxidation, production of ketone bodies. The release of lactate and ketone bodies in blood, these are the acid compounds. According to the balance between production and elimination rates of lactate and ketone bodies, there is risk of lactic acidosis. So, what are the cardiovascular protective effects in diabetes by metformin? The UKPDS data was the first to show a cardioprotective effect of metformin. This has been confirmed in several observational studies as well. This is a graph from the UKpedia study. Here we can see that number of events in patients who are on metformin as compared to other conventional glucose control methods is less in terms of sudden death and in terms of myocardial infarction. Also, a Cochrane review looked at 29 trials with a total of 5259 patients. In these trials, obese patients allocated to metformin show greater benefit compared to sulfonylureas or insulin for any diabetes related outcome and all cause mortality and diabetes related death or myocardial infarction. Although RCT data is lacking on this subject, but metformin is now established as cardioprotective. A post UKPDS follow up study showed continued reduction of risk in the metformin treated subjects. What are the contraindications before starting the metformin? First is renal impairment. Plasma creatinine values of more than 1.5 milligram per deciliter for men and more than 1.4 milligram deciliter for women are relative contraindications. More recently, there is evidence to suggest that it can be advocated with a creatinine up to 1.7 milligram per deciliter. Patients who are cardiac and respiratory insufficiency that is likely to cause central hypoxia or reduced peripheral perfusion are also the contraindications. However, there are studies to show that it can be tolerated in class 4 cardiac failure provided the renal functions are normal. So, metformin dose we have to adjust based on the renal functions. If eGFR is more than equal to 60, there is no contraindication to metformin. We have to monitor the GFR. We can give the standard dose. If eGFR is less than 60 but more than 45, we can continue metformin, but we have to frequently monitor the GFR every 3 to 6 months. If the eGFR is more than 30 but less than 45, then we have to prescribe the metformin with caution. And if it is less than 30, we should not use metformin. So continuing the contraindications for metformin, if there is any history of lactic acidosis, severe infection that could lead to decreased tissue perfusion, liver disease including alcoholic liver disease, especially CTP-B and C. Interestingly, there are studies to show that it may inhibit hepatitis C viral replication also. If the patient has history of use of IV radiographic contrast material, then that is also a relative contraindication. So advantages and disadvantages metformin. Advantages, it is inexpensive. There is no risk of hypoglycemia. Once a day administration is also possible. There is long history of use. There is no weight gain or maybe weight loss, and it may decrease the cardiovascular disease. And but the disadvantages include GI side effects, B12 deficiency, lactic acidosis, and we have to monitor the renal functions. So next, coming to the thiazolidinediones. These are the ligands for an orphan nuclear receptor peroxisome proliferator activated receptor PPAR gamma. They exert the insulin sparing action by activation of this PPAR gamma. So in this diagram we can see that thiazolidinediones act on a nuclear receptor and exert their metabolic actions like increasing the insulin sensitivity, increasing the HDL cholesterol, decreasing the triglyceride and decreasing the blood sugar levels. So the class of this class drugs includes rosiglitazone and pioglitazone. They selectively agonist of PPR gamma. They bind to this receptor, activate the insulin responsive genes, regulate carbohydrate and lipid metabolism, leading to inhibition of hepatic glucogenesis. They promote lipogenesis and they increase glucose transport into muscle and adipose tissue. Hence, ultimately, they aid in lowering of blood glucose. So they increase the insulin sensitivity by increasing peripheral uptake of glucose in muscle and adipose tissue. They also lower the hepatic glucose production to a lesser extent and they stimulate oxidation and lipogenesis in adipose tissue. They increase the GLUT4 transporters in adipose tissue. They promote fatty acid uptake and storage in adipose tissue, resulting in a decrease in circulating fatty acids and a decrease in fat accumulation in the liver, muscle and pancreas. Drugs of this class include troglitazone, pioglitazone, rosiglitazone, and lobeglitazone. They decrease the insulin resistance and thereby enhance the biological response to endogenously produced insulin as well as exogenous insulin. So coming to pioglitazone, we usually initiate this drug at 15 mg or 30 mg once a day with or without food. We use 15 mg in patients where there is concern of fluid retention. If there is inadequate glycemic control, the dose can be increased in 50 mg increments up to a maximum of 45 mg OD. Because the maximum effect of thiazolidinediones on glycemic control may take 10 to 14 weeks, we should wait for at least 12 weeks before deciding whether to increase the dose of these drugs or not. Pioglitazone and rosiglitazone, they decrease the HbA1c level to a similar degree as metformin and sulfonylurea therapy. The decrease in fasting plasma glucose was observed as early as second week of therapy, but the maximal decrease occurred after 10 to 14 weeks. This differs from other hypoglycemic drugs where the maximal effects occur more rapidly. So these drugs lower both fasting and postprandial glucose levels. They are more effective in improving glycemic control in patients with marked insulin resistance, and they also don't cause hypoglycemia. Lobeglutazone, it undergoes extensive metabolism in the liver via cytochrome P450 enzymes. This drug and its metabolites are primarily eliminated through feces and urine. The usual dose of lobeglutazone is 0.5 mg once a daily. What are the therapeutic applications of thiazolidinediones? The important second and third line oral antidiabetic agents, their potential single daily dose with pioglitazone, that decreases the arterial blood pressure minimally. They progressively increase high density lipoprotein. They are safer in moderate to severe renal failure. They decreases microalbuminuria. They decreases vascular intimal thickening. They can also be used in patients with renal insufficiency and PCOS. Studies with pioglitazone have suggested a beneficial effect on cardiovascular disease. The main study is proactive study. Pioglitazone has beneficial effects on NAFLD and NASH patients as well, though they are not FDA approved for these disease. They, by improving the insulin sensitivity and decreasing the circulating androgen levels, improve the ovulation rates and improve glucose tolerance in patients with PCOD. What are the adverse effects of these drugs? They can lead to weight gain, ankle edema, congestive heart failure, fluid overload. These are dose related side effects. They can also lead to hepatotoxicity. Potential, however, there is low risk of bladder carcinoma, bone fractures, macular edema, ovulation, and pregnancy. So the thiazolidinediones, by acting on the PPAR gamma receptors, they can exert acute effects, they can exert chronic effects. The acute effects they exert by non-genomic mechanism which lead to stimulation of proximal tubule sodium transport, and by the chronic effects by genomic mechanism they enhance the expression of distal nephron sodium transport. By both of these mechanisms they aid in volume expansion and edema formation. What are the contraindications? We should not prescribe these drugs in patients with volume overload states, patients with hepatitis, either acute or chronic, patients with macular edema, dysthyroid ophthalmopathy, osteoporosis, and patients with active or past history of bladder cancer. So coming to the advantages and disadvantages. Advantages for these drugs, we have once a day administration possible, reduces cardiovascular side effects, durable effect, they reduces the incidences of NASH, there is no risk of hypoglycemia, they are relatively inexpensive, there is no dose adjustment for renal disease, they increase the HDL cholesterol and decrease triglycerides. But they have disadvantages of edema, cardiac heart failure, weight gain, osteoporosis, bladder cancer, macular edema, or small increase in LDL cholesterol. Now coming to the last topic for this video, alpha glucosidase inhibitors. So drugs in this class include acarbose, miglitol, voclibos. These agents are primarily used to reduce postprandial hyperglycemia without increasing the insulin levels. They are competitive and reversible inhibitors of pancreatic alpha amylase and membrane-bound intestinal alpha glucosidase hydrolase enzymes. They have a minimal effect on the fasting glucose concentration. They lower the HbA1c levels by 0.5 to 1%. So in this diagram, we can see that oligosaccharides are breakdown by monosaccharides by alpha glucosidase enzyme in the intestine, and hence they are absorbed and which lead to postprandial hyperglycemia. But when we give these drugs, alpha glucosidase inhibitors, they compete with oligosaccharides for this enzyme, and they decrease the chances of postprandial hyperglycemia by impairing the absorption of monosaccharides. So alpha glucosidase inhibitors compete with the oligosaccharides and they delay the absorption of complex carbohydrates. Carbohydrate absorption occurs more distally in the intestine, reducing the postprandial increase in glucose and lower the prandial insulin levels. Side effects of these drugs include flatulence, diarrhea, abdominal discomfort. Acarbose, when given in doses excess of 50 mg TDS, it may give rise to elevation of serum transaminases and in rare instances hyperbilirubinemia. So what were the advice we will give to the patients? They should start at the low dose and go slow. The drug should be administered after the first bite of each meal or no later than 15 minutes after the beginning of each meal. Prefer nutrients with complex carbohydrates like rice, pasta, full bread, vegetables and fruits. We should avoid refined carbohydrates like sugars and sweets. We should avoid laxatives such as sugar alcohol. So what are the available agents? Acarbose, it inhibits the pancreatic amylase. The usual dose is 50 mg per day with the first bite of each meal. The maximum dose is 200 mg per day. Voclibose, it inhibits the most alpha glucosidase enzymes like glucosamylase, sucrase, maltase and isomaltase. The usual dose is 0.2 to 0.3 mg per day with each meal. Miglitol has no effect on pancreatic amylase but exerts an inhibitory effect on non-intestinal alpha-glucosidase present in other cells of the body. The starting dose is 25 mg thrice daily with the first bite of meal and the maximum dosage is 100 mg. So the clinical use, these drugs must be given at the start of each meal. They are effective only if the diet consists of 40 to 50% of carbohydrates at least. They're extremely effective in the treatment of severe hyperglycemia following the GI surgery and other forms of reactive hyperglycemia. The contraindications to starting alpha glucosidase inhibitors are diabetic ketoacidosis, chronic intestinal diseases characterized by marked digestive or absorptive disorders, hypersensitivity to miglitol, IBD and other conditions which may deteriorate the increased gas formation, intestinal obstruction, cirrhosis. Acarbose and miglitol should not be used in patients with creatinine more than 2 mg per deciliter. Acarbose and Miglitol are contraindicated in patients with severe renal impairment, especially when GFR falls below 30. However, voglibose has negligible renal excretion and it can be used in patients with CKD. Concurrent use of Miglitol and a sulfonylurea may result in the risk of hypoglycemia. So we should not use these two drugs simultaneously. And also, since Miglitol delays the absorption of sucrose, oral glucose should be used if hypoglycemia occurs. So coming to the advantages and disadvantages for these drugs, the advantages include there is no risk of hypoglycemia, they are weight neutral, they decreases the postprandial glucose, they are relatively inexpensive. And disadvantages includes they have GI side effects like flatulence, diarrhea, they have frequent dosing schedule and they have to be avoided if there is renal disease, especially creatinine is more than 2 or GFR is less than 30. So this is the last take home message slides. So we have discussed today about the 5 classes of oral antidiabetic agents: insulin, secretagogues, sulfonylureas and non-sulfonylureas. We have discussed about metformin, thiazolidinediones and alpha glucosidase inhibitors. So in this table we can see that sulfonylureas, the mechanism of action of both secretagogues is increase the insulin secretion and they reduce the HbA1c by 1 to 2%, while the non-sulfonylurea secretagogues reduce the HbA1c by 0.5 to 1%. Sulfonylureas have shorter duration of action, they lower the postprandial glucose and they are inexpensive. And the glenides, the repaglenide and netaglenide, they also have shorter duration of action, they also lower postprandial glucose. The disadvantage of sulfonylureas, mainly we have hypoglycemia and weight gain, and the disadvantage with non-sulfonylurea secretagogues, we have hypoglycemia. The contraindications for sulfonylurea includes renal and liver insufficiency, and for repaglenide and netaglenide, we have renal and liver insufficiency, especially with the netaglenide. So for metformin, its mechanism of action decreases hepatic glucose production, enhances the insulin sensitivity, and influences the gut function. It reduces HbA1c by 1 to 2%. It is weight neutral, do not cause hypoglycemia, inexpensive, and decrease the cardiovascular events. The main disadvantages of metformin includes diarrhea, nausea, lactic acidosis, B12 deficiency. And the contraindications, as we have already discussed, renal insufficiency, especially in patients with GFR less than 30 ml per minute, patients with congestive heart failure, patients who have received radio contrast studies, hospitalized patients, and patients who already have acidosis. For thiazolidinediones, the mechanism of action mainly by decreasing the insulin resistance and enhancing the glucose utilization. Main drugs of this class is pioglitazone, rosiglitazone. Also, we have lobeglitazone. They reduces the HbA1c by 0.5 to 1.4%. The advantages of these drugs is they lower the insulin requirements, but the disadvantage include they promote peripheral edema, congestive heart failure, weight gain, fractures, and macular edema, and they should not be used in patients with liver and renal insufficiency and who have congestive heart failure. Lastly, the alpha glucosidase inhibitors, they decrease the GI glucose absorption. The drugs of this class include acarbose, miglitol, and voglibose. They reduce the HbA1c by 0.5 to 0.8%. They mainly reduce the postprandial glycemia. The disadvantages of these drugs include GI flatulence, elevation of the liver enzyme, and they should be avoided in patients with renal and liver insufficiency. Thank you.
The first and foremost thing is how to optimize oral antidiabetic drugs in a type 2 diabetic patient.
The choice of oral anti-diabetic drugs for any patient is individualized. We have to see what is our goal for the patient, whether we have to target the fasting blood sugars, we have to target the HbA1c or postprandial blood sugars. We need to look for the comorbidities that the patient have, its BMI, patient's renal function and liver functions, and after all these analysis we should choose a oral diabetic agent for the patient.
Okay, and of course, I think one of the most important parameters is age as well.
Yes.
While deciding upon the oral antidiabetic drugs. Say, for example, those antidiabetic drugs which are prone to cause hypoglycemia, especially sulfonylureas, which is having a prolonged duration of action,
Yes.
should better be avoided in this.
In such patients, we can use non-sulfonylurean insulin secretagogues like repaglinide, netiglinide,
Yes.
which have similar efficacy and low chances of hypoglycemia.
Hypoglycemia. Also, the glipizide as well as you can say extended release
Yes, sir. Gliclazide
glyclazide can be used in elderly population in comparison to glimepiride, which is more prone to cause hypos.
Yes.
And also metformin is quite safe in this population, elderly population. And the drugs which should be better avoided in geriatric age group is one is basically thiazolidinediones for the risk of osteoporosis, and of course potent sulfonylureas which is having a long duration of action like glimepiride one. And definitely there are certain baseline investigations that can predict the outcome of action of sulfonylureas or maybe other OADs. So what are the other parameters that should be incorporated apart from clinical parameters like phenotype of diabetes, like BMI, like comorbid status, like longevity, or maybe age per se? So are there some biochemical parameters also that can help you in deciding upon the role of oral antidiabetic drugs and their efficacy in real life scenario?
For thiazolidinediones, we can use the ratio of urinary C-peptide and urinary creatinine.
So this is a good marker for predictions. The patients who are having a high urinary C-peptide to creatinine ratio, they fare very well with the thiazolidinediones as compared to other secretagogues or maybe metformin. And a special mention should be done for females with diabetes, especially the young onset diabetics who are having difficulty in conceiving. So I think the best part is to utilize metformin
Yes.
as anti-diabetic because it really reduces the androgen levels as well as insulin resistance, which is basically driving these patients for not conceiving or maybe frequent pregnancy losses. So clinicians do not use quite frequently the drugs apart from sulfonylureas. So what is your take on using these other drugs, say for example alpha glucosidase inhibitors or maybe netiglinaids, so far as tackling the fasting or postprandial blood sugar is concerned?
Considering the vast availability of options that we have, we should explore all other oral antidiabetic agents.
So Dr. Rafika, is it possible to combine oral antidiabetic drugs from the same group? I mean to say sulfonylureas or sulfonylureas plus other secretagogues for those patients especially who are not uh, willing for starting the insulin or whose longevity is not much?
We can combine, sir, insulin secretagogues from two different classes because they act on different receptors and they have different pharmacokinetics and duration of action. So we can combine like a long-acting sulfonylurea with a comparatively short-acting glinides, or we can also combine two sulfonylureas like glimepiride and glipizide. Since glipizide is short-acting, it will act on the postprandial glucose levels, and glimepiride is long-acting. It can act on the basal levels of blood glucose.
So optimizing and using the mechanism of action, you can combine these drugs. So for
Yes.
example, natilinate can be combined with other secretagogues sulfonylureas because they do act through different mechanism of action. So is it pertinent to wait for going to the maximal dose of one drug, then switching over to other OAD, or would you recommend to use the combination of drugs since beginning?
If initial HbA1c or blood sugar of patient is high, we can go for combination of drugs. By this, there will be reducing the risk of side effects with a particular drug, and we have benefits due to multiple different mechanism of action of lowering the blood glucose.
Yes, so baseline HbA1c is one of the important predictors to identify the patient population in whom you can wait, in whom you can start the combination as a whole. The patients who are really uncontrolled should be started with combination therapy since beginning, and the one who are having a mild diabetes can be managed with one single agent. But it is said that you should not use more than 50% of the recommended dose of oral antidiabetic drugs of sulfonylurea group, because the receptor is almost 90% occupied with 50% of dose. So it is imperative all the dose, say for example glimepiride is 8 mg, but the moment you reach 4 mg, you have already achieved 90% of its efficacy. So going beyond 4 mg, say for example going to 6 mg or maybe 8 mg, is not going to yield a desirable clinical effect. So that is the time when you should add another drug from different group, and similar holds true for other sulfonylureas. So I think a clinician should not wait till he reaches the highest maximum dose of one single sulfonylureas and then add. So the moment you reach 50% of the recommended dose, you start foreseeing the failure of this drug in future follow-ups of the patient, as there is hardly any improvement in the glycemic profile, and it is imperative to add another group of drug for optimal management of diabetes in short term as well as long term diabetic patients. So I think we will discuss other issues in next class. Thank you very much.